Hi everybody, this is Mrs. Poindexter. This is going to be a quick overview of the topics that we covered in class regarding perioperative nursing. So again, objectives, make sure you understand the role of the nurse in the different phases. Pay special attention to complications, things that you would educate patients, the role of the nurse with informed consent, identify comorbidities that can impact a patient's perioperative experience and care, and the role of the nurse as it relates to surgical asepsis. Here are the lecture materials that you need to review. Again, know your patient population. Think about what constitutes elderly. Usually think of patients 65 years or older, children, smokers and your diabetics. Again, some of the issues we talked about in class was about slow healing with diabetics and smokers. And also to think about patients with disabilities. And one thing I didn't talk about, we did talk a little bit about those with intellectual disabilities, but think about patients with hearing impairment, visual impairment, like wearing glasses, those who have hearing aids, dentures, glasses. Know that these are personal belongings and they may be essential to a patient's care. So kind of be mindful about that as you move along through their perioperative experience. So before surgery, make sure you go over the components of a patient's history, their current medications over the counter, any bleeding disorders, allergies, any problems with heart and lungs, endocrine disorders, if they have any pre-existing mental or physical disabilities, and of course pregnancy status. Make sure that they hold anticoagulants for 7 to 10 days prior to surgery. Other things to be mindful, make sure they have had nothing by mouth, and you sometimes want to clarify that that they haven't also chewed gum, had candy, anything like this, because chewing gum actually stimulates the acids in the stomach and sometimes can cause some trouble with anesthesia. Again, that just needs to be clear with the anesthesiologist, but make sure they understand what nothing by mouth means. Updated history and physical, and of course know what your role is with informed consent. Again, not to beat it into your heads, but to beat it into your heads, informed consent. Know what your role is. Again, you are to be a witness. It is the responsibility of the doctor to obtain consent after talking to a patient, going over the risks and benefits of surgery, and answer all their questions. You are clearly just witnessing their signing of the consent form. You can clarify some information, but if it starts getting into particulars about recovery or things that you just do not know the answer to, kind of going beyond your scope and going back to the actual discussion of the surgery, you will need to call the provider. Consents are needed for basically anything that is invasive. And also informed consent is needed for things like medication, restraints, invasive procedures, seclusion, and even electroconvulsive therapy. What constitutes for a patient to be able to give consent? They need to be 18 years or older, mentally capable, and not under the influence of any medication that can alter their judgment. And once you've gotten informed consent, your documentation is the reinforcement of information provided by the provider, any irregular occurrences, and if the use of interpreted was needed. And again, an interpreter cannot be a family member. It needs to be somebody who has gone through proper training, is licensed, and also either an employee of the hospital or a third party that is approved by the hospital to use. Again, have common sense when it comes to patient allergies. Interop, that's basically when the patient has gone into the operating suite. The handoff, basically make sure you have the right patient, what the procedure is, that if there's a laterality to be marked, that it has been marked, that the patient verifies this. Part of your role as an interoperative nurse is patient advocacy, maintaining their safety, making sure they're properly positioned, keeping their dignity, that they're not cold. A lot of the time the OR rooms are kept at a cooler temperature just because elevated temperatures kind of increases the multiplying of bacteria. So basically colder temperatures are usually in the OR suites, and the type of sedation that is used and their side effects. Understanding aseptic technique. If somebody turns their back to a sterile field, is no longer sterile. Knowing the patient prep, making sure they don't have any allergies to it, and the time out. Instrument and sharp count, and of course proper documentation. Malignant hypothermia, like we talked in class, make sure you understand what it is, what the triggering agents are, and make sure you understand treatment. So you want to stop surgery, administer IV dantrolene, which is a muscle relaxant, 100% O2, obtain ABGs, infused iced, IV normal saline, cooling blankets, and indwelling catheter to monitor eyes and nose. Spinal headaches, make sure you know what it is and understand what the treatment is. Remember, it manifests when the head of the bed is elevated. The headache is painful, so make sure you want to keep the patient nice and flat to promote the dura-tear to seal. Keep the environment quiet, hydrate them to help replace the loss of the CSF, and also if all these things don't work, sometimes they have to do what's called a blood patch. Surgical asepsis, we talked a little bit. So basically above the waist is sterile, and this is really not a good picture because you see here their back is turned, but basically the front is considered sterile, and this technically, turning the back would mean we would assume this is unsterile, but as we progress, dress for the zone, this was more or less talking about when you do your OR rotation. Different places are a little bit different, but for example, the unrestricted zone, this is where you can kind of walk in your street clothes. Semi-restricted zone, you need to be wearing scrubs and a cap. In the restricted zone area would be scrubs, cap, and a mask, eye protection, any other equipment that was needed depending on what the surgery is. Post-op nursing care, this is going to be when the patient has either gone to the floor or has gone to the PACU unit, which is the post-anesthesia care unit. That's what PACU stands for. Frequent nursing assessments are vital. Patient airway, you want to keep it patent. Head of bed, 15-30 degrees unless contraindicated. If patients are feeling nauseous, turn them to the lateral position. Again, as long as it's not contraindicated. Watch their lines and drains if you are moving patient around. They're at risk for hypotension and shock if more than 500 mLs were lost during surgery. Watch for signs of hemorrhage. Again, this can be low blood pressure, increase pulse rate, hypertension and arrhythmias. Stay ahead of the pain, anxiety that's related to it, nausea and vomiting. And if it's outpatient, making sure that all questions are answered during discharge teaching. Here are some different postoperative complications. Again, like I covered in class, you don't need to know every last nitpicky detail, but just kind of understand what it is and some of the main interventions. One thing I did mention in class is make sure you know how to teach somebody how to use the incentive spirometer. And here are some more of the complications, just to review. Make sure you know the difference between wound dehiscence and wound evisceration. And when I think of the difference between the two, I would think evisceration, think E for exit, that part of the bowel might exit the body to help kind of differentiate between the two. You're going to see possible problems with wound wound healing with those that are immunocompromised, those with some nutritional deficits, problems with maintaining or controlling their blood sugars, having too many elevations, and of course our smokers. Common meds you should know, your antiemetics. So when you hear things like Zofran, Phenergan, and Reglan. And here, if you stop and think, how does Reglan help? Sometimes if people are having some peristalsis, things aren't moving, it can kind of cause some nausea. So kind of get things moving, kind of helps with that fullness feeling. And then again, the anticholinergics like the atropine, that can decrease bradycardia during surgery, due mainly to the manipulation of surgery. Your antidotes like vitamin K for Coumadin and the protamine sulfate for heparin. And some basic discharge criteria. It depends on what facility you work at. They can vary a little bit, but these are just some basic ones. Again, make sure that you review the skill modules, surgical asepsis. I think I also mentioned if you look at your ATI table of contents, there's one about perioperative care that might be good for you to look at as well. And that's about it. So a little over 11 minutes of overview. If you have any questions, email or post to the test discussion board. Take care.